Wonderful. Good morning and good afternoon to our colleagues who are joining us from around the world. We are pleased that you are here today to join us in this discussion about highlights from the Nigerian and Honduran Ministries of Health. We'll be looking more closely at how we've been able to leverage HIV situation rooms for strengthened outbreak response to COVID-19. I am pleased to be here with you today, and we have Mr. Uduak and Mr. Damba joining us from the Nigerian Ministry of Health, and we have Dr. Pamela and Dr. Alicium joining us from the Honduran Ministry of Health. My name is Jenny Mwanza, and I'm a Senior Technical Advisor with Data.FI, and I lead our data use portfolio. Just a little bit of background about the Data.FI data use strategy. We are currently working across 5 different countries, and we have over 30 situation rooms established. Situation rooms are often also referred to as epidemic control rooms or emergency operations centers. So this methodology was spearheaded in Nigeria at the request of the USAID mission to provide a forum to allow stakeholders to analyze data in real time through a structured intervention, promoting continuous quality improvement to accelerate HIV prevention and control. To share a bit of background with you, in 2020, WHO published the Consolidated HIV Strategic Information Guidelines. And these guidelines highlight key recommendations for successful data review. And we'll review these throughout the presentation. So at the outset, it's important to be able to convene a multidisciplinary, multi-level stakeholder groups. And then in the second piece is looking at a standard core set of analysis that allows for routine data to be able to be brought together to inform management decisions. And those questions being asked are to be adapted at the different levels. Continually reviewing the data to be able to act on the findings and conclusions to adjust service delivery. So really a focus on how our decisions go beyond coordination and really are tied to improve service delivery, supervision, and/or resource allocation. And of course, an emphasis on continually returning to review the same indicators over time to monitor if indeed we are having the intended impact. So in the Data.FI support that we've provided to these 4 governments, we work under the leadership of the Ministry of Health. Our intervention is characterized by several key aspects that appear across all the countries. Most often, we're working at the subnational level, though we also work at the national level. And we've been able to change the way in which we're approaching data use to promote an environment where stakeholders are motivated and willingly come together on a weekly basis. We see participation of over 15 individuals at each one of these meetings. And you'll see in each of the 2 different countries we're highlighting today what those stakeholders look like and how they've changed from HIV prevention and control to COVID response and vaccination. So one of the key principles that we use in HIV or COVID situation room setting is that stakeholders are engaged around prioritized indicators and that we're drawing from different perspectives to understand the root causes for the perceived underperformance. In so doing, we're routinely coming back to the same validated analyses, and those are analyses that will often triangulate data from different sources. So an example you'll hear about is how we've been able to bring together both surveillance and vaccination data under a COVID situation room to be able to continually view progress from different perspectives. So much of the work that we do is focused on using quality improvement tools to tie data interpretation to tangible actions. And then again, continually reviewing and coming back to the same priority indicators to see and to evaluate if what we have accomplished as a team is actually having the desired impact. So with that introduction, I am happy to introduce to you Mr. Uduak Umo Udofia. who is the M&E officer for the SASCP at the State Ministry of Health in Akwa Ibom State. And he is here today to share with you their experience in the HIV situation rooms. Over to you, Mr. Uduak.
Okay, good afternoon. My name, as Jenny has said, is Mr. Uduak Umodofe, and I'm the SASCAP M&E officer for the Ministry of Health in Akwa Ibom State. So we are going to be talking about how the Situation Room has improved our HIV response. Next slide, please. Next slide. So while I was invited today to share our experience in the situation of Akwa Ibom State, I want to first begin by giving a general overview of the situation rooms, how they actually came into being in Nigeria. And with the help Nigeria, with the request of the Nigerian government, that requested USAID to also help in providing support, not only for our HIV response, but also for data use for improvement. After our own situation room was launched in May 2019, we had another set of COVID emergency operation centers that were established in 2020 around 8 different states in Nigeria. And from then on, in 2021, the Ministry of Women Affairs also asked for a situation room to be established, and they looked into OVC issues. The next one was in 2022, where the National Agency for the Control of AIDS established a national HIV situation room, which they are now even calling the Command Center, and they are looking into also HIV affairs. And then lastly was the situation room that was launched in Taraba State, and I need to just mention that the Taraba State team even had to come to Akwa Ibom State in that year 2022 to come and understudy what we were doing. Next slide, please. Okay, so in Akwa Ibom State is located in the southern region of Nigeria and is one of the states with the highest prevalence. Our current estimate of HIV prevalence has been put at 5.5%, and this was after a NIA survey had been carried out in 2018, where Akwa Ibom came out with the highest prevalence, as said before. In 2018, we had only about 35,000 individuals who were receiving treatment out of an estimated 175,000. So you could see that we still had a lot of unmet needs in the state. And then with that, we still needed to, we had an 85% proxy retention rate. So that means we were still losing a lot of people who were coming in and were going out of the program due to loss of follow-up issues. So despite a lot of investments in the collection of management of data, information was actually underutilized for routine program and performance improvement. So it was with this that USAID support came in through Data.FI, and they came and supported the Ministry of Health to restructure a mechanism for enhanced data review called situation rooms. Next slide. So since 2019, the situation rooms have been on ground. And if you look at this slide, you will see that the conveners of our situation room has been done by the State Director of Public Health and our Director of Planning, Research and Statistics, because they are the stakeholders mainly when it comes to data. And the moderator of our situation rooms has been done by our SAPC, who is the State AIDS Program Coordinator. And then the stakeholders for this meeting has been with members of the Ministry of Health. We also have the SASCAP team, and then we have implementing partners. And our implementing partners, we have a few of them like JPIGO. We also have TMEC Rise, and then we have FHI 360, CHI, AIDS Healthcare Foundation, CCRN, and a whole lot of them. They've been joining us up for our meetings. I just need to also state here that Data.FI has been providing trainings in data analytics for our staff with a range of topics such as GIS, infographics, and compelling visualizations. If you see the picture, then you will see that this was what during one of the trainings we were doing on infographics, and it was a wonderful one. It actually built the capacity of the government of Nigeria staff. Next slide, please. Next slide. Next slide. So we are since that 2019. So this graph now shows the impact observed in acquired mistakes. As you can see from the slide one there, number of newly diagnosed HIV positive. The situation was launched in 2019, and you can see from that first graph that since then we've been having an increase in the number of newly diagnosed positives, and that has actually increased up to December 2021, where we had a median increase of new diagnosis of 15,000 sustained over the last 2 years. The next, if you look at the second slide there, you will see that we've had a linkage. We started with a linkage of 84%, and this has gradually increased over the years to 2022 to about 99%. The number of people that have been placed on treatment has been increasing gradually over the years, and over the last 3 years, you would believe that we've had over 200,000 that have been placed on treatment. So as of December, we were at 242,000. Viral suppression has also improved over this period. We've seen that it started at 78%, and suppression, as we know, is a major concept that will help us in the reduction of the epidemic burden. And so, as it is now, as at the end of 2022, we had a viral suppression of 99%, which is showing that we are doing quite well. Next slide, please. Okay, so we had to begin to move beyond just looking at our general population. And we began to place more focus now on our PMTCT program, that's prevention of mother-to-child transmission, and also our pediatrics. And you can see from that number one graph that we have there, that our linkage has improved amongst the pediatric, the young ones. It started at 55% as at 2021, and has increased up to 113% by December 2022. The second graph there now also shows, because we needed to improve on our TLD transitions amongst the pediatrics, this has also improved over the years. It started from 11%, it stalled a bit at 46% in 2021, but it gradually increased again. And because we were now using a PDSI cycle, which identified where we were having issues, we've had further quality improvements up to 97%. Again, even if you look at our viral load coverage for pediatrics has gone up to 91%. So you see that we have done so much better in the past 3 to 4 years since we will be able to begin to talk together and began to use our situation rooms. So as it is now, our coverage for pediatrics is at 91%. Next slide, please. Viral suppression. If you look at the last slide there, our last slide is actually talking about, just shows the situation room. And people begin to think that the situation room is just about having the presence of technology or having internet connectivity. But I want to say it goes beyond that. It is with the collaboration of stakeholders and with the bringing together of people together. And that has made the difference in our situation rooms. And you can see that because of that, we have had multiple people who have been part of us in using the same data. We come together, we discuss, we share accountability, we find solutions and our challenges. And this has shown that this situation room concept has worked. There's a quote there by my SAPC. There's a lot of accountability, different stakeholders talk week in, week out. Every partner is made accountable, and the different steps are delegated to different partners, not to the whole group. Thank you very much.
Wonderful. Thank you, Mr. Uduak. So we will now transition to your colleague, who has been part of the leadership team activating the COVID Emergency Operations Center in Adamawa State. I'm pleased to welcome Mr. Damba Quinque, State Epidemiologist from the State Ministry of Health in Adamawa State. Mr. Damba, please, over to you.
Hello, can you hear me now? Hello, can you hear me?
Yes, we can hear you.
So thank you to this wonderful presentation. Sorry, you can not see my video is unfortunate, but I think you can hear me well. So Adamawa State Emergency Operations Center and challenges as at 2020. As we all know, in 2020, when the pandemic started, we had several challenges, and these challenges ranges from poor coordination mechanism within the PHEOC, which enable us not to test well, and we have restricted or limited number of test kits, which were challenges to enable us quickly diagnose our COVID-19 cases. We have also surveillance information system that collects COVID-19 data, which was very slow in adaptation. And we have another problem which ranges from the system of vaccination data collection and the image data collection and the data calling, which is aggregation in number that we have to use the text messages. And relatively, we had low demand of the vaccines of the pandemic due to the minimal cost effect on the population. People think it is not deadly. So, however, it was just unfortunate that the start of the pandemic, there was low mechanism of coordination and within the EUC. And the surveillance system, which is the use of SOMAS, SOMAS was just concentrating on the IDSR notifiable diseases, the 45 IDSR notifiable diseases. It was not capturing the COVID-19. And unfortunately, there were delays in updating the system for COVID-19. Vaccination data was also a problem in collection due to ad hoc calling system. The existing routine immunization was not involving or including the COVID-19. And the demand for the vaccination was actually too low from the community and from the people of this COVID-19 pandemic. Next slide. Next slide, where we have leadership structure and capacity building. Actually, there was a capacity building for the staff on 3 basic areas. We had the information system that was surveillance, outbreak response management, analysis of SOMAS. Our staff from the local government and the state had this training. When the data analysis, the GIS, and the EOC from the state and the local government officials were all trained on that to enable us operate effectively. Data use improvement, we also prepare and compel establishment for end statement, testing change ideas, and continued education of our staff to improve the knowledge of this EOC staff. However, we were able to actually improve on the staff of the EOC on training them on these activities. The State Minister of Health actually convened this training, and this training was actually handled by the state epidemiologist, and we have our state DSNOs who was the owner of the problem that was consulting the program, and he is the one that was handling the notification of the problem. of this program. We also do the overview training to help activation of the EOC in the state, which provided and was supported by the Data.FI. And we began to focus on strengthening the SOMAS to include COVID-19 and including the COVID-19 and other notifiable diseases. Next, we were able to sustain the EOC staff to strengthen their capabilities on how to use SOMAS. Finally, we work with the EOC staff to deepen their understanding on the quality improvement strategies. We also reviewed the compelling visualization and establishment of the continued training education of the staff of the EOC. So these are the achievements we had in 2023. We actually succeeded in convening weekly meetings as the EOC demands. We had to discuss and disseminate the reports through situation report CTREP. We have to improve in coordination, strengthening communication between the surveillance unit and the vaccination unit. We have to use data source, align fragment system to gain more accurate pictures on the ground on surveillance and the vaccination system. We have to also improve vaccination of high priority groups. Next slide. Next slide, please. Good. Now, go back, please. Next slide, next slide. Next slide.
Sorry, there's a slight delay, Mr. Damba.
Okay, sorry. Thank you.
This slide,
So
perfect. Please continue, sir.
The vaccination data in Adamawa State as this 30th April 2023, we have reviewed our coverage in vaccination in Adamawa State in 2021 April. Adamawa has surpassed, and generally we have covered over 100%, and we're drilling down to review our vaccination coverage at local government levels. So we saw that we have 4 LGAs that were actually unable to meet up to that 70% expected standard of coverage. And at present, we are working on to bringing these 4 LGAs that were unable to meet up this 70% coverage. And these LGAs are Madagali, Michika, Danye, and Gombe. Reason being they are on a security compromised areas, while Michika and Madagali were bordering with Maiduguri, where we know insurgency is deepened, and including Gombe. But Danye is also bordering with Cameroon, which we know is another challenge. Our targeted vaccinated population is 2,698,928, while we have successfully completed the vaccination of 2,860,355, giving us a percentage coverage of 106%. Next slide. Yes, in our state's cumulative as at April 30th, we were able to vaccinate health workers 84%, people living with HIV 1%, people aged 50 and above completed vaccinated 76%. And looking at week 1 to week 16, 15, we were able to vaccinate up to 70%. And because of the training we had, there was little improvement from week 16, covering up to 73%, up to week 17. As at week 18, there was great improvement, 75%, and from week 21 to 22, we have to reach up to 76%. This is as a result of the improvement in the training we had by the EOC staff. Following this training, there is great improvement. Notably, we prioritize healthcare workers, we prioritize people with age 50 and above, and people living with HIV. Epidemiological week 14, we conducted a workshop to identify strategies aimed at increasing our coverage, as earlier discussed, which include the elderly. So we have mobilized AFNet, African Field Epidemiology, and to help target these elderly people. We also concurrently doing social mobilization through the risk communication pillars to help mobilize and help educate our people on the importance of these vaccinations. In just 7 weeks, we were able to increase our elderly vaccination to 76% as noted on our screen. Next slide, please. Next slide. Sorry for the delay on the movement of the slide. Good. So the Ministry of Health, we actually harmonize our approach across the country. As the Honorable Minister of Health has shared visions to coordinate response on all hazardous events, irrespective of their cost. To this end, on December 2022, the Federal Ministry of Health actually completed assessment on EOC Joint External Evaluation with Data.FI support. This assessment that was done actually identified EOC activations and the gaps existing within the EOC. As you can see, the trends of what actually was done in the 12 thematic areas for the PHEOC, though only number 4 and number 11, where we had no access to those activities with technical working group members identified and with financing committees trend, but the rest had one or other percentages that were looked into. So with this assessment, the Data.FI supported the development of the M&E framework against which states can measure their own progress. So we had to measure our progress, and the graphs here on the left-hand side depicts the EOC across Nigeria as at December 2022. So looking at the vision of the Honorable Minister, by December 2022, Federal Ministry has, alongside with Nigerian Center for Disease Control, NCDC, were able to activate EOC in all the states and using the checklist to monitor and measure the improvement on the EOC in these states. This checklist identified gaps which are pasted on this left-hand side. Next, the national stakeholders participated also on the workshop to design a strategy for which integration of diverse emergency operation centers and situation rooms can be operated. As part of this effort, Data.FI supported the development of the M&E and the framework against which state progresses were measured. The EOC assessment resulted presented here as prioritized within the M&E framework. We were able to optimize our EOC with expanded program immunization within the EOC center. So this has necessitated the strengthening and preparation in advance to see how we can mitigate any impending outbreak. Next slide. So this is actually the plan and activities done to prepare against any impending outbreak. So this is what is happening in Adamawa State. Thank you very much.
Thank you kindly, Mr. Damba. So we have just heard from Nigerian situation rooms in both the HIV context and then how they were transformed to the Emergency Operations Center in Adamawa and 7 other states in Nigeria, as well as some of the national initiatives to expand the EOC approach across Nigeria. So shifting gears and shifting hemispheres, we would now like to invite Dr. Pamela Oliveira, who is the COVID-19 and Influenza National Coordinator of the UVS of the Ministry of Health of Honduras, to speak about their experience with COVID-19 situation rooms. Also to share that we will have an opportunity for questions and answers at the end of the presentations. If you would like to write your question into the chat, we'll take that into account when we get to the questions. Super, and thank you, and over to you, Dr. Pamela.
A pleasure to be with you today. I will present the COVID-19 situation rooms in Honduras. Next slide. While I have been invited to speak today about the Honduras experience with situation rooms, I will begin sharing some history. Salas situacionales, I will say in Spanish, have their origins inside war rooms to support decision-making in the time of war. Situation rooms looking at the health began in South America, with the first one, Brazil, focused on health sector decentralization. In Honduras, we have a concept of situation rooms since 1995. It was with the arrival of COVID-19 that the idea really took hold. PAHO helped the Ministry of Health equip physical space with technology. In March 2022, Data.FI began supporting the methodology of the situation rooms, providing guidance for how we engage with and use data for decision making. Next slide. At the onset of the COVID-19 epidemic in Honduras, we organized coordination meeting by programmatic area. Surveillance teams meet separately from laboratory, case management, and vaccination. Data.FI supports that changed the way we were working together with the ministry. By bringing together data from across the Ministry of Health, we prioritize indicators and we have an opportunity to work together. By including everyone in the situation rooms, we make our work more efficient. Analyses are constant, giving everyone access to the same information at the same time. We track each individual action, which means promises are respected. Finally, we make good use for our time. We usually meet for 1 hour or 1.5 hours with a preference for keeping meetings short so that we can meet regularly. Next slide. Next, please. While the first case of COVID-19 appeared in Honduras in March 2020, it wasn't until April 2022 that efforts were made to address stock out of COVID test kits. In the context of the situation rooms, we brought together technical leaders from planning, surveillance, and laboratory to solve the problem of why we were running out of COVID-19 test kits. As a result of situation rooms discussion, we found short and medium-term solutions. We were missing basic information about available stock at the local and regional level. We immediately began doing a physical inventory of testing supplies. In August 2022, we implemented a digital system to track carded testing supplies. We were able to track warehouse distribution to health units and daily usage of testing kits. By September, we resolved the stock out issue. Next slide. With the arrival of COVID epidemic in 2020, government health facilities were overwhelmed. So we created a temporary additional health structure called Centros de Triaje or triage centers to keep all with testing and needed for case management. Just as the government was closing triage centers, we began meeting regularly in the situation rooms. We knew the COVID service will still be needed after the closure of triage centers. However, there wasn't a clear plan. Inside the situation rooms, we analyzed the surveillance data alongside information about existing health facilities. We developed a plan for training human resource and distributing COVID supplies into the existing health system. So by April 2023, we have fully moved COVID diagnosis and case management into existing health system. This solution requires participation from many actors in the Honduras health system. Then, to the situation room, we have an opportunity to analyze the data and make a coordinated transition. Next slide. Next, please.
I think there's a slight delay. You should see it in just a second.
Okay. In Honduras, many factors have favored high vaccination coverage. As of May 2023, we have vaccinated 60% of the general population. However, we have also suffered from difficulties in tracking vaccination data given parallel reporting system. Certain data have been sent directly to the Expanded Program on Immunization, EPI program. Other data were reported to the Regional Ministry of Health. In the situation rooms, we found an example where one group reported 81% vaccination coverage and the other only reports 68% vaccination coverage. Following the discovery, we worked together to clean two data to ensure the parallel system report the same figures. The long-term solution is to eliminate parallel reporting, but we have not yet been able to. Next. In December 2022, Situation Rules leadership invited the Ministry of Education to understand challenge preventing youth vaccination. As a result, the Ministry of Health and the Ministry of Education worked together. We developed vaccine allocation plans to maximize coverage in a school-age population. Next slide. Our epidemiology coordinator, Dr. Aaron Bueso, shared a message of who I would like to share with you. Through the national situation rooms, the 20 health regions have been invited to participate in the real time to identify gaps and strengthen the response to COVID-19 as a country. Thank you.
Wonderful. Thank you so much, Dr. Pamela. So in Honduras, we had an interesting situation where we first began with the COVID situation room. And from there, we actually have been able to open the HIV prevention and control situation rooms. I'm pleased to introduce to you Dr. Lician Valladares. She is our country director for Data.FI Honduras, who will speak about this experience. Over to you, Lician.
Thank you, Jenny. Good morning, everyone, and thank you. As Dr. Pamela mentioned, we have been working with situation rooms in the Secretaría de Salud de Honduras since 2022. However, it's important to mention that we were called to stand or to support and implement situation rooms methodologies during the time of emergency. That meant that we would implement the data use strategy that not only improve quality, but also accountability within situation rooms in the country. So there was, as she mentioned, there was a lot of coordination to improve COVID response initially and to ensure that the vaccination activities continued. So we began working in the country's two largest regions, La Metropolitana del Distrito Central and San Pedro Sula. And as one of the leading staff in the Secretaría de Salud told us, if anything can happen within these two regions, anything can happen in the country. And we can see that as the opening of the national situation rooms that was launched on September 2022, and is a room that supports all regions in the country, the 20 regions in the country, to convene and analyze data. So in early 2023, we added the lens of HIV prevention and control to our portfolio. We began by organizing indicator prioritization and analytics development, which was helpful in bringing the stakeholders together, which is one of the most important things that can be done while working on HIV. Shortly after that, we expanded to the region of Cortes, and that was in March this year. In total, the Ministry of Health has convened 43 regional situation rooms meetings and 3 national situation rooms for COVID-19 and HIV combined, depending on the situation and the aim of the UVS technical lead. Next slide, please. So since March 2022, situation rooms meetings have been convened by the regional health director, and the meetings are moderation is usually rotated by the lead epidemiologist, and we have a broad participation from a range of stakeholders, including communication staff, strategic planning, health information systems, amongst others. Data.FI has supported a number of trainings, starting with orientation of the methodology and facilitation training. This is important because it's important to improve soft skills and also to promoting ownership and effectiveness in the communication for actions implementation. So as we are getting started in HIV, we plan on providing a refresher training on HIV cascade to ensure good alignment between PEPFAR and WHO guidance. They're also preparing a master facilitator training that the regional national leadership can cascade to other regions. Next slide, please. But there is one thing that is always important, and I always mention, that is not only the situation system is a structure within the country. So we have a broad response, which is good. We have a lot of implementing partners from different areas, from the CDC, from USAID, from the Global Fund. But what does that happen when there is not a strong leadership? So we have a fragmented HIV data system. So as you can see, there are 3 systems collecting data about new HIV diagnosis, but there are also 3 different systems collecting information about those who are newly diagnosed and linked to HIV treatment. As such, we see very different results from the percentage of those who are linked to HIV treatment and those who are part of the cohort and receiving attention. These numbers can range from 30 to 90%. This does not mean that the people are not receiving treatment or are not enrolled. That means that there is a lag in the information system that we need to improve. So this is a result of a multiple fragmented HIV data system, which do not communicate among to each other. Next slide, please. So what have we done and how we can see the improvement in the data quality? So we have brought together system owners. We have sat with the implementing partners. We have seen that each information system was capturing a different piece of information. We were able to manually correct the data, and moving forward, we are reporting lines are more clear. And there is an ownership from the Ministry of Health in which they are requiring all the information that is generated by the implementing partners to be facilitated timely to the regional level so it can be reported. And as a result of this investment in data quality, the linkage has increased from 30% to 90%. We can now begin an initiative to address actual improvements in service to ensure that 100% of new positives are linked to care efficiently. The very act of trying to use the data for decision-making revealed the data quality issue and accelerated finding the solution. And the solution was, as we have seen, improved communication and really strong partnership with all the ones who are key implementers in the response to HIV in the country. So our information systems, and bottom line, our information systems are fragmented across many areas, but the long-term solutions require a unified HIV architecture in which we are all providing support. Next slide, please. And I think this is the last slide. And so I'm waiting for the next slide. So I see this is important, that our vision for the future of situation rooms has to be institutionalized and has to expand and diversify. So we have a strong commitment to the situation room methodology moving forward and setting the example for other regions to start implementing. In March 2023, the National Coordination of Surveillance of Infectious Diseases, or UBS as we call it, decided to officially incorporate the data use strategy into the National Situation Room guidelines. Also, moving forward, all situation room meetings in all regions of the country will reflect Data.FI data use methodology, including participatory problem solving, engagement of diverse stakeholders, frequent comparison of performance against targets to inform corrections. So we have a vision of expanding into the remaining 18 regions throughout the country, and we will offer a master facilitator training to the national leadership who will in turn cascade the trainings to facilitate all the regions with the support from USAID. And of course, what we hope is that the methodology will be applied beyond COVID and HIV. We are optimistic that we can follow similar process to analyze and understand monkeypox. We have been done, and also start working on global health security data. So that is our hope for the future, and we hope the future is bright. So thank you very much. If you have any questions, over to you, Jenny.
Super, thank you, Dr. Alicia. So I'd like to take this opportunity to thank our speakers from Nigeria and from Honduras and share a few words in closing. We have just been reviewing our numbers after 4 years of implementing situation rooms and have recorded over 2,000 situation room meetings at the district, subnational, and national levels. So it's a really exciting time for us to be able to sit back and to look at what are the key characteristics that have made this strategy really take hold in these countries. And what we believe we're promoting is really a change in the culture in ministries of health around engaging with data, making it less punitive and making it really an opportunity to work together. We have seen different groups of the ministries of health come together and really for the first time having an open dialogue. We think so much of this is around our value add in information system strengthening, analytics, and data use. That we engage these different groups in the design of their analytics around their priority questions together. So we are in that way able to maximize the investments that we're making in information system strengthening. So many of the examples we've shared today actually highlight how before we can get to improving performance of services delivered, we've really worked on resolving data quality issues. Oftentimes, we know and we see that systems are built in parallel and that those parallel reporting systems and the misalignment of systems needs to be resolved as the first question in a data use conversation. So pleased that we have this ability to work both across information system strengthening and the data use spectrum. And lastly, we've really seen this methodology evolve and its ability to be flexible. So while it was first promoted as a solution in HIV prevention and control, It was quickly adapted for COVID-19. And in other settings, notably in Guatemala and in Tanzania, we worked really successfully with partners in primary healthcare. So the methodology is the same and adaptable across different disease priorities. Also to note, we're planning a second webinar coming up this summer to highlight that experience in Guatemala and Tanzania around primary healthcare and situation room work there. So with that, I would very much like to open up the floor for questions for our colleagues from Nigeria, Mr. Uduak and Mr. Damba, as well from Honduras, Dr. Pamela and Dr. Alicia. I will pause, and if you have a question, please do raise your hand and we will unmute you so that you can speak out your question. We have about 5 minutes remaining on our meeting. And if you prefer to write your question in the chat, happy to read it out from the chat as well. Oh, thank you so much, and over to the plenary. Super, super. So there's a large silence, but I would like to myself ask some questions perhaps of our panelists. From the Ministries of Health, would anyone like to share about which level this intervention seems to work well at, if it's applicable at the lowest levels, the intermediary levels, and the national levels? Thoughts or comments on the level of data use strategy?
Feel free, anyone to take, any of our speakers to take Jenny's question, whoever, in whatever order. Or we can move on to Chris's question I see you asked in the chat. Can I ask if there are any challenges with compiling data for meetings or any gaps in the data? Anyone care to take that question on?
Oh, happy to support on that. Hi, Chris. Yeah, that is always such a challenging part of the process because of the information systems are not aligned. We're not in the case of COVID in Honduras, either in the case of HIV, because there are many subsystems and even ways in which the teams want to present the information that does not support like up-to-date analysis. So that was been always a challenge. We had data from regional level, we have data from hospitals, and then we have to triangulate all the data. So at the very beginning, it was very complicated. But now that we have gotten into a way of working, we are seeing it easier. We are also, as Jenny mentioned, in order to have the data, we need to align and provide a strengthening to the health information system. So we have been working together with other USAID implementing partners to have up-to-date and for them to provide the information to the government as well, not only their own systems. So over to you. I hope I had answered your question, Chris.
Super, thank you. And we see that we have a question coming in from Augustine. Augustine, we will unmute you and you can go ahead and ask your question.
Great, thank you, Jenny and team for the wonderful presentation. Augustine Okindo from Kenya. So my question is around identifying the stakeholders who participate in the situation rooms and how you get to have them join. Because one of the challenges we have had with the government is getting them to sit down and participate. And maybe on the same, could you please tell us the most difficult part working with these stakeholders once you have identified them?
Thank you, Augustine, for your question. And can I ask that Mr. Uduak respond to that question? Mr. Uduak, the selection and working with stakeholders, please, over to you.
Yes, we get our stakeholders, like I said earlier on, from our implementing partners and also from our stakeholders within the Ministry of Health and within SACA. To get them, the best way we get it is through our online visualization. That is, we do our meetings consistently where we time ourselves and tell them, please, you have to be here for 1 hour. We have to be here for 1 hour, 30 minutes. And after that, there will be no time to discuss anything again. And gladly enough, we've gotten used to this situation and they join. And when they join, we do ask questions and we do also discuss together and get the answers together. And then we do also, as we go on, we delegate responsibilities when we do deep dives. So that we do deep dives into different, like we were talking about, different subsets, different subpopulations. And these are normally the responsibilities of different partners. And when we do this, we discuss together and ask them, we delegate functions and to see how we can get gaps closed and corrected. So, but they do, when we do call for meetings, initially we used to have those challenges of people sitting down in the meetings. But once you tell people a meeting is 1 hour, 1 hour, 30 minutes, and they know they're not going to spend all day long in those meetings, they will attend. So that has helped us.
Wonderful. Thank you, Mr. Uduak. It's lovely to hear from you. So with that, I think we're closing in on our hour. I would like to especially thank our presenters who did such a great job preparing their achievements from their different countries and contexts. And at the same time, I'd like to share that we will be posting a recording of this webinar and also announcing the date for our next webinar in the series. So thank you to all of the attendees who made time for us today, and feel free to continue to share questions or to reach out to us should you have any further points you'd like clarified. So thank you so much. To everyone, have a good morning or a good evening, and we wish you well. Thank you.
Thank you so much. We really appreciate you.
Thank you, everyone. Thank you very much.
Thank you.
Have a good day. Good evening.
Thank you.
Congratulations.